This patient came to the hospital on February 19th. He came in with an extreme headache, and his medical diagnosis upon admission was renal insufficiency and hyperkalemia. His inpatient diet order was a renal diet. He had an independent feeding ability and no oral problems. Patient was a 77-year-old male. He was 70 inches and 137 kilograms, which puts him at a BMI classification of class 3, and his BMI was 43.62. The patient appeared to be obese. He was very calm and alert and oriented when I went to go see him. The reason he triggered a consult was because he needed nutrition education. As you can see by his labs, his potassium was critically high at 7.2. Also, his BUN was critically high. And also, as you can see, in regards to his renal insufficiency, his eGFR was very low at 11.49. Also, his phosphorus, as you can see, was also very high, which is also something that relates to his renal insufficiency. During his hospitalization, though, he was dialyzed. He is not a dialysis patient, but considering his labs, he definitely needed to be dialyzed. His past medical history includes a newly diagnosed head mass, which is presumed aspergillosis, which is a fungal infection, coronary artery disease, hypertension, obesity, obstructive sleep apnea, prostate cancer, gout. He also has had carotid surgery and urinary incontinence, as well as cervical neck arthritis. His medications that he was on during his stay at the hospital include the first one, voriconazole, is an antifungal medication. He also was on Augmentin, which is an antibiotic, insulin for his diabetes, and the lorastatin, Lasix, and the Corig are all antihypertensive medications. Crestor is an anti-hyperlipidemic. The omeprazole is an anti-GERD. Uloric is an anti-gout medication. The Norvasac is also an antihypertensive, and the loratadine is just Claritin. It's an allergy medication, and the Testim topical is a testosterone topical gel. The patient's skin was intact, and his Braden score was 23. His estimated nutrient needs were based on 75 kilograms, which was his adjusted body weight. So his calorie needs were 2,000 calories, 60 grams of protein, and 1,900 milliliters of fluid a day. His nutrition diagnosis includes food and nutrition related knowledge deficit, and this is related to his lack of education regarding high potassium foods, which is the reason why we had a consult for this patient. And the signs and symptoms, obviously, his potassium levels were critically high. Second diagnosis, undesirable food choices, and this comes from his consumption of high potassium foods. And again, his potassium level was critically high when he was admitted into the hospital. So the intervention was nutrition education, discuss and provide education materials to the patient regarding high and low potassium foods. When I went to go see this patient, his wife was in the room, and I had looked over his chart and just kind of looked at his diet, came in, talked to him about his diet. I provided him with a list, actually a couple lists of high and low potassium foods, and just discussed the importance of this with his kidney disease. And I had noticed also with his diabetes that in his chart from his physician that he was drinking orange juice when his blood sugar was low. So I had to explain to him that he could drink other juices, such as cranberry juice, to help with his blood sugar without consuming a high potassium food. So the monitoring and evaluation for this patient would be his lab values again, and we would like to see his potassium in a normal range of 3.5 to 5. Also, another one would be his phosphorus levels. This wasn't as much of an importance at the time, but I did discuss this with him as well. I mean, all the handouts I brought were all on renal disease and just acceptable foods and just the importance of consuming foods within limits. And the patient and his wife were both very receptive to this information. And as you can see, for his abnormal labs, again, his potassium was the main problem in regards to his consumption of high potassium foods. His blood glucose, I attribute this to his type 2 diabetes. And then you can see his BUN, his creatinine, and his EGFR are all abnormal due to his renal disease. His calcium levels, they were at 8.4, which is low, and this has to do with his elevated phosphorus, and his phosphorus, again, was elevated because of his renal disease. So when I did his calories, they were based on, I did like between the Mifflin St. Jeor and his adjusted body weight and just kind of averaged those. His protein 0.8, he does not receive dialysis frequently or regularly, so his protein needs are as high as a patient that would be on dialysis all the time. And his fluid needs were estimated by 25 milliliters per kilogram of his adjusted body weight.